welcome base campers to virtual base camp. First of all, did everybody get a good parking spot? Because we want to make sure that you had a convenient spot. It's free parking. Secondly, the temperature of the room. Like, make sure you're comfy, you got that going on. That's great. So when I last saw you guys, it was March 4th. Can you believe that? I was on my way to Scotland, and I haven't been back to the clinic since. From returning to Scotland, isolation, and then they shut down the clinics. So it's been 26 years since I've had this long a break in clinical practice, and maybe it's that same length for you as well. And you know, in the background, I've always been preaching about the VUCA world, that it's volatile, it's uncertain, it's complex and ambiguous. And you know, it helps us to understand disruptions. Well, we're experiencing the biggest disruption you can possibly imagine. And how do you manage the disruption? There are a couple of ways to do that. So first, you have to sense that something's going on. Well, we've done that. You have to respond in such a way that's for the best information at the time. You've got to learn, and then you have to adapt to the situation. So all of us are really good in that we're learners. So I think it's going to be, it's going to be an interesting time, because the future right now is actually unknowable, right? We don't know what the heck is going to happen, but there are two types of futures. There's the certain future, which is we know it's going to be dark tonight and light again tomorrow. And then there's the disputable future, which is something that we're going to try to figure out together. And you know, the unknown is uncomfortable, but we're all in this together. So we're here to go through it together, and we'll get out of it together as well. And our story today is our future history. Can you imagine the stories that we're going to be able to tell in 10 and 15 years from now to people coming into this world? One of the things that has really helped me through this crisis is a framework called 5 C's. It's the 5 C framework for managing this terrible disruption. And I'm going to share it with you. The first is caring. Caring is something that we need to do more than we've ever done before. We need to take care of each other. The Bill Withers song plays over and over on my playlist, that Lean On Me song, and it gives me great comfort. So we have to care about each other, and you know, I care about my teams and my community and my network, and you know, I think about my study club, and it's really important that we look out for each other. So caring is number one. Communication, staying in touch, staying linked, that's really important, and thank goodness for technology, because this would be such a different story 15 years ago. Trying to navigate through this. So communication is really important. And the third C is clarity. So we want transparency, we want authenticity and honesty. So although the messages sometimes aren't great, we want to be clear about them. And the fourth C is calm. We have time. This is a proper crisis, but we've got time to figure this out. You know, we're going to get through it. We don't have to make any rush decisions. So it's good that we stay calm. And the fifth C is collaboration. So no one is smart enough to figure this thing out by themselves. And the best that we can do is we can join together on our teams, in our regions, in our provinces, in our countries, and internationally, globally. And then together, through our collaboration, this is going to be a positive outcome. So with that, the topic today is on collaboration, and it gives me great pleasure to introduce my colleague, Dr. Louisa Schult, who started with us in January and has entered the clinical world in Niagara under some fantastic circumstances here. And she's going to share her journey, and she's going to present today on the collaboration between dental specialties and periodontics. So with that, I will give Louisa the stage. Is that what it's called? The stage? The screen? And I'd say join me in welcoming Louisa.
Thank you so much, Peter. I've just realized that I'm missing you just about as long as we were together. missing the whole team, our patients working together side by side. And yeah, it's going to be a little bit longer for sure. Welcome everybody to this new and innovative learning experience. Before jumping into this, I wanted just to share a little bit about myself with everybody here. My most recent schooling was at UBC, some of my team members. But I guess my journey into dentistry and into periodontics didn't really start there. I knew I wanted to serve my community and help the people around me in some way ever since I was a small child. And I ventured into a few different areas, unsure of which one would be the right fit for me. And in dentistry, I was very fortunate to find something I was so passionate about, just as passionate as I am about helping those around me and working with the community. I wasn't sure which area to specialize in, so I did have the opportunity to practice general dentistry for a little while. Then I focused on prosthodontics for quite a while, especially implant dentistry. And when I had the opportunity to go back to school, I seized that opportunity and went into periodontics. These are some of my team members as I was going to school, a wonderful group of people to learn with. And in the bottom photo, that's a picture of myself and one of my classmates training with a wonderful instructor from Europe, Isvan Urban. And on that opportunity, we were actually treating Miss Piggy. No real patients for ourselves that day. Another very important thing that absolutely changed my world, I don't know if any of you guys noticed on the photo I was showing you with my classmates, there was a little bump in the picture. This little man came into the world a few months before I finished my periodontics training, but 1 month before doing my board examinations. For any dentistry colleagues out there joining us today, or dental hygienists who have had to do similar examinations, you may know just how much pressure we're under at that time. And it just happened that that's when this gentleman decided to join us. And he has created a whole new challenge for me, which is finding some balance in an area that's just not balanceable. My passion in the work field and just watching him grow and learn and navigate the world. It's quite a challenge, and those who are parents out there probably feel the same way. This is my little Nicholas. And now I'm fortunate enough to have a whole new family. Thank you for making me feel so welcome. From the first day when I started to visit well over 6 months ago, and we were trying to see if this was a perfect place for me to be. And now that I've relocated, moved into the community, and been able to see you all so much more often until about a month ago. Thank you so much to each and every one of the team members here that have made me feel so welcome. So we have been navigating the Perry and the Peninsula lectures for a little while now, hosted by Peter and all the other team members. Thank you for the wonderful team of hygienists who have been collaborating on this. We are so close to the end of this series of lectures, just a little bit further to go. We can see that cusp already within reach. One difference between the fellow that's on this cusp and us is that we didn't get here alone. We've been navigating this together. So a lot of different topics have been seen over the last few months. We've talked about periodontal health, how to manage periodontitis, the importance of periodontal maintenance. Several lectures have been over implant dentistry and the importance of also maintaining dental implants. And now we are reaching our 11th lecture, Periodontal Linkages with Other Specialties. And today I hope to add one more little drop of information and curiosity and knowledge to each and every one of you. I know that Dr. Peter Fritz and Amanda and the hygienists have really set the bar high with their wonderful lectures. So I hope I have at least a little bit of success today in sparking some of that interest. Our objectives for today will be to review the important role of each team member, exploring the new dental technologies and how these can have a huge impact improving communication and treatment planning, case presentation, and understanding how dental specialists can work together to create improved clinical outcomes for our patients, which I think that is truly our ultimate goal, helping our patients achieve ideal dental health. The topics are going to be covered in this order. We're going to start with the dental team, communication in the digital era, periodontal linkages to each of the specialties. We'll go through ortho, endodontic, and restorative dental therapy, whether that is a prosthodontist or the general dentist. Starting out with the topic of the dental team, it's so important to remember that each of us would not be here and doing our work daily without the support of each of the other team members, whether it is administrative team, whether it is the team of hygienists, general dentist, our external collaborators, representatives of the different technologies and materials we use inside of our dental practices. We have a large support team that allow us to provide the services that we hopefully will be providing again soon. We cannot succeed on our own. Failure we can do on our own. So it's wonderful to have the help of others to keep us away from that area we don't want to go to and have success not only for ourselves, but for our teams and for our patients. A couple of the things that are most important when working with a dental team is seamless communication between all the people involved, which would include patients, dental hygienists. I'll go a little bit more into who these team members are in a moment. And also that we need to learn from each other. And the best way to learn is actually if we share what knowledge we have. I think I'm very fortunate in that I have been able to live and travel to many places in the world, and I don't think I've met anyone who hasn't taught me something. So we should always be open to those learning experiences, whether it's a patient, another team member, or someone we're meeting throughout this crisis. There's so many opportunities to learn. So who is the dental team exactly? I was mentioning some of these people actually work within our offices and our practices, and we see on a day-to-day basis, and some of these people we don't. So the patient, the general dentist or dental specialist, hygienist, and assistant, we're all it's easier to be more cohesive. We're working together more consistently. But there are people outside of our doors that we work with all the time as well, which would be the laboratory technician. Most dental practices will not have one in-house. There's a few, especially prosthodontic offices that may, but most of us do not have laboratory technician support within our walls. Dental specialists are often also outside the walls of the general dentist, and people providing research and developing technology are not usually within our walls either. They're working in their laboratories and preparing things that we can use and implement to improve our quality of care. And that's actually the area I'm going to work on or talk about first. Those great advances and different technologies that have been created to make the treatment we're providing more seamless, faster, easier, more comfortable for our patients, and also reaching their expectations more easily. One of those things is everything that's been developed in the area of digital technology. So that would be digital photography, digital radiography, CVCT, which are the 3D scans, digital impressions or optical scanning is another name for that, digital treatment planning, which can take us from step A, virtual implant treatment, providing all the treatment in a computer atmosphere before having to touch the patient, and even designing the prosthetics. So it's a quite innovative technology, and it's created to make it easy as well. And another area that this digital treatment planning has been developed is in orthodontics. So the dentist, the orthodontist or general dentist can take the patient again from step A to making some of the movements they're going to do during their treatment and take them all the way to the final result without having moved any teeth. You can do it all virtually first. General advantages of these technologies is that there can be a seamless communication. It's very easy to share this technology between specialists or lab, even when we're not within the same walls. It is immediately accessible for everyone. There's no time that we have to send a package and wait for it to arrive at the other specialist or dental professional's office. We can store these for a long time in a minimal amount of space. We don't have to worry about storing all these little boxes, preserving x-rays that, you know, if they weren't completely fixed, start to turn green over time or get scratched just being in storage and rubbing against staples. They can be intact for an indefinite amount of time. And we can integrate all these different digital technologies for that workflow I was mentioning, where we do the digital treatment planning and design everything from A to Z prior to treating the patient. There are a few small disadvantages though. Hacking, which right now we're on Zoom, and some of you may have heard that even Zoom has had these issues of hacking. Now that's why you were all asked to insert a password prior to logging on. Encryption as well, because we are dealing with patient confidentiality. So all the information we're sharing and exchanging has to be encrypted. And you never know if there's going to be a power outage, some sort of damage to our information. So a digital backup is required as well. Those are very few disadvantages and quite a few larger advantages. The most important thing in communication is hearing what isn't said. And I think we've all heard as well that a picture says, 100 or 1,000 or whatever number of words. So being able to share these images when it comes to radiographs, photographs is just a wonderful luxury we have in today's world. So I think many of us are quite familiar with the importance of photography for, preserving information regarding our patient prior to treatment. If we're monitoring pathology, it can also be quite useful. But when we used to take photographs in the non-digital world, we had no idea what that photograph looked like until the photograph was developed. And I'm sure we all have cases, whether it's family photos or professional photos, where the result was just not what we expected. Now we can look at these photos before we've even touched the patient, have a sense of what the quality of the image is. We can adjust exposure or contrast as needed. We can even do a digital mock-up. So I'm going to show you a couple of those later on. This is a really lovely patient I had the opportunity to work on. She had a little accident when she was 12 years old. Her absolute best friend, her horse, gave her a little kick in her mouth. And at that point, nobody really noticed anything had happened until she was 19 years old. And it turned out that she had about 2 to 3 millimeters of root left on her tooth. And that would be her before and after. That tooth was removed and replaced with a dental implant. She has her temporary restoration in place there just a few days after surgery. I was mentioning the mock-ups. So this is a patient that presented unhappy with her gummy smile, and we'll talk a little bit more about this case in a few minutes. But here we can do a very simple digital mock-up, just laying over a template and planning, some ideal contours for her gum line, better proportions for her teeth, and having a good idea of what her smile is going to look like after her surgical procedure. But we don't have to stop just at simple digital photography. We can do a lot more with digital photography now. This is one of the examples of what's out there. This is Smile Design by 3Shape. So this system lets us play with those templates. The photograph can be taken in any way, whether it's a digital camera or even just a simple iPhone. The photos uploaded into the system and the templates can be placed over the patient's smile. So this patient in particular, her teeth were quite short, had a gummy smile, but also had recession on another tooth. You guys can see her 2-2 has some recession. Being able to plan the treatment in this format and explaining the initial and transitional points of treatment where we were going to do some crown lengthening, some soft tissue grafting on her lateral, veneers were made. This is very easy to plan and communicate with the patient, with the restorative dentist, and even the lab, so that the tooth shape that they designed for her is ideal and all planned right from the beginning of the treatment. But digital photography isn't the only new technology. We also have digital radiography. So there are some advantages compared to our conventional radiographs, and one of those is the magnification or detail that these sensors can have. We can zoom into different areas of the radiograph if we want to look at more detail, depending on the quality of our of our sensors. We can manipulate the contrast. We can look at certain detail. We do not lose any quality if these have to be shared. If we have to make duplicate radiographs, sometimes those won't turn out quite as well as the initial. It is also eco-friendly in that it is chemical-free. We're not throwing away or recycling the lead foils. It is very easy, as I said, to share, and it can also facilitate patient education. If we bring this photo up on our screen and really make it larger, it gives us the opportunity for patients to understand a little bit better. And when we look at OLARA principle, the sensors are very sensitive, so as long as we've adjusted our machines, we can use a lower dose of radiation and have the same quality of image. There are some disadvantages as well. We have to update ourselves, our skills. Our hygienists or anybody else in the office taking in radiographs will have to do that as well. We also have to update software consistently. At some point, this may become obsolete, and then there will be a new technology to invest in. But in that sense, slowly, I think we are already transitioning to a world where digital radiographs is more mainstream, and slowly the conventional radiographs are passing on to be less common or less ideal. The sensor size can be an issue. They are a little bit bulkier. They have a wire attached to make it a little bit more complicated to take these images. The sensors need to be replaced if they are damaged, or if we're using the PCPs, which are the smaller, not as long-lasting sensors that are scanned in separately. Those need to be replaced more often. Another big disadvantage is that we cannot sterilize these, not that we sterilized our conventional radiographs either, but because they are going from patient to patient, we have to protect everyone, and then barriers are used to do this as opposed to sterilization. And there I've just showed you a few images of some of the things that we can do on the digital software. Our conventional image, just black and white, is the one we should use for diagnosis, but sometimes with presenting with patients or looking for final details in the root, sometimes contrasting, making the negative, or playing with some of these filters can be of great assistance. CVCT is also now the biggest new gold standard for dental imaging. It gives us so much more information than our conventional radiographs will. It is an adjunct to our conventional 2D radiographs. So most patients will first have a 2D radiograph, and then as needed, the 3D or cone beam computed tomography. People sometimes refer to them as tomographs or 3D scans. The CVCT or cone beam tomography is the more common name. We can, again, just like with our digital radiographs, these images can be manipulated, but in many more ways than our conventional radiograph. We can actually turn these images around, look at different slices, look at them from any direction we would like. So it will drastically improve our ability to diagnose. And if we can diagnose better, it helps us treatment plan as well. I have a little video from our colleagues, endodontists.
Trained to treat diseases of the teeth. Endodontic care aims to resolve both dental infection and pain, in addition to managing cases of dental trauma to save patients' teeth. We do this in some of the smallest spaces in the human body, treating disease and infection that is microscopic and virtually invisible. Over the years, technological advancements have allowed endodontists to see what they previously could not. Most notably, CVCT, or cone beam computed tomography, has allowed us to do just that. Similar to a medical CT scan, CVCT represents an innovative medical imaging technique that provides endodontists with three-dimensional views of the patient's tooth or jaw. It has increased our ability to detect structures hidden in traditional X-rays, including cracks, unusual tooth anatomy, and atypical diseases inside or around a patient's tooth.
CVCT scans produce three-dimensional images similar to traditional medical CTs. The CVCT, however, is more advanced and can produce a 3D image of a very specific area in just one rotation of the machine. This occurs within seconds and without the patient having to lie down. CVCT scans specifically focus on small areas of the mouth, resulting in radiation dosages several hundred times lower than traditional medical CTs, even lower than a chest X-ray. Before the scan begins, patients are protected by a special apron that covers the torso, both front and back. Once the apron is placed, the patient is positioned in the scanner to accurately and precisely capture a 3D image of specific teeth and the surrounding structures. The scan only takes a few seconds. The patient just needs to stand or sit still. The scanner rotates once around the patient to capture a complete 3D image. Finally, the endodontist carefully reads the 3D image on the computer. The image can be viewed using different slices and angles to provide vast amounts of useful and important information. The endodontist may enhance images and measure anatomic landmarks to better assess teeth and other structures. This invaluable resource allows endodontists to develop patient-specific treatment plans that will appropriately manage their condition.
Overall, the CVCT has greatly assisted endodontists and helped with patient care in many clinical scenarios. Ask your endodontist if this special X-ray technology may help in your diagnosis or treatment.
Okay, well, I'm back. I hope that was a nice little break from hearing my voice. And while we were watching that video, I actually realized just, how different this is from our conventional webinar. Thank you to all of you. I'm actually kind of sitting with you in a way in your homes. Just sitting with you on your couch, discussing dentistry. It's a quite unique experience. Going back to our lecture, we were talking a little bit earlier about Alara, and it was mentioned in the video just how low radiation is on this type of image. So generally, the amount of millisieverts that we want our general public to be exposed to is just 1 a year. And Alara wants us to keep our radiation as low as reasonably achievable. The amount of radiation we are generating with this is actually quite low, and we can share the images once they've been taken. We only take images the size required, so we can take a full mouth of 8 by 8 centimeters, but generally when we're assessing 1 or 2 teeth, it'll be a very small scan, only 5 by 5 centimeters. And here is just a simplified guide explaining something that's actually quite complex, but it compares to some of the other sources of radiation that we have. Even eating a banana will add a little bit of radiation to us. So dental CTs are actually quite low and safe to take whenever we actually need one. And CVCTs can be applied in just about any dental field. In endodontics, as they were mentioning in the video, it's used principally to assess for root fractures, looking for variations in root anatomy, including accessory canal, lacerations, any calcifications within the root canal system. They wanted to confirm the location or extent of periapical lesions. So if it's on the mesial or buccal root, sometimes we cannot see that in a flat image. In periodontics, we'll look as well for root fractures. We can also assess the extent of internal or external resorption. So that patient that I showed you earlier on that had that root resorption, that was external root resorption. And the best way to assess that was a 3D scan. We can assess oral pathology, bone deficiencies. We can perform implant planning, including virtual surgery. In orthodontics, it can be of great use as well to assess craniofacial anomalies and also impacted teeth, like our impacted wisdom teeth or impacted canines. Here's an example of a 3D scan or CVCT. We can see the loss of bone on the buccal plate, the ideal position for that implant. That position can be assessed from every angle, correlating it to the adjacent teeth, the residual bone, to the nasal cavity. So the implant surgery, in a sense, has already been performed and the patient has not been touched. We can explain to the patient why that bone deficiency needs to be treated and why some bone grafting will be performed along with the placement of the dental implant. Ideal angulation can be planned. CVCTs have really come to change the way we treat patients. And I would consider that this is kind of the next technology. Some places it's already been implemented, not quite as widespread, and that would be our optical scanning. So these are impressions that are done without the need of impression materials. No more trays, no repeating impressions. So it's a wonderful tool. A few different brand names are there. They're all pretty similar in that they have a scanner that goes into the mouth, and we watch on a screen of some sort while the scan is being managed. So here's a list of some of our advantages. So as I was saying, no impression material, which I know most of our patients dislike, no matter what we do to them, adding flavor, making them a little bit faster. I don't think there's a patient out there that would say they enjoy the impression phase of treatment. We can reduce the gag reflex by not having a mouthful of impression material. Sometimes it's still a little bit uncomfortable to place the scanning instrument towards the back of the mouth, but we can place it, remove it, and put it back in the mouth as many times as we need to help get the patient through the process of doing the scan. There's no waiting time between an uncovery and an impression because it can be done at the same time. There's no impression material going in underneath the gum line. It is quite fast. We don't have to wait for the setting of the impression material and then have to worry about obtaining the cast. Margins, if this is for a crown, it can be assessed immediately and not have to wait to see that cast to make sure we've captured the entire margin. And in infection control, some people might say, well, that scanner is being reused and you have to put shields over it. And that's true. But in infection control, I think that's something very easy to do. And we don't have to worry about casts or impressions being transported to the lab and back that are not sterile and could be a source of contamination. This is an example of how the scan will work. This is real time. So this is one of the fastest scanners, the Cerix scanner. And this scanner can actually be set up with a milling machine in office if that's what the dentist wants, to make some of their own crowns in office, or these images can be sent digitally to the lab. Can scan soft tissues, hard tissues. Now it took about 30 seconds, which is quite fast for if we compare to, alginate, having to mix it, place it in the mouth, waiting for it to set. It also speeds things up. We can do the scanning, do a clinical validation, ensuring that we've captured what we need to capture before sending this electronically. So we can be 100% sure everything is there before we dismiss the patient. The impression is sent. The restorative, whether it's a crown, bridge, it can all be fabricated on the computer as well, which would be the CAD design. It can be assessed before fabrication by the general dentist, restorative dentist, the lab. There can be an exchange and modifications prior to manufacturing, and then it's fabricated and seated. So there are steps all along the process where there is communication and back and forth of information. And every time that information is shared, it's immediate. It can be shared and discussed and modified in a similar way as we are right now, doing a conference call or a Zoom call between the lab and the dentist. So we were discussing a little bit earlier already about scanning and how much of an aid it is for diagnosis. We can 3D plan the implant case, place the implant, to do an optical scan. Even some people will do it even day of surgery. I would not recommend jumping because teeth do change while the mouth is healing. But at time of uncovering is a wonderful time to do an optical scan, and the restoration can be fabricated also all digitally. And in orthodontics, it's also quite useful. Another video to share with you. And this is just an example of an optical scan or intraoral impression. Takes only a few minutes to upload, and the software will plan all the changes the orthodontist would want. And they still have an opportunity to review and make any modifications they would want to make to the planned treatment. You can shift teeth very easily. This can even be placed tentatively as a mock-up into the patient's mouth so they can see their before. And with a template of their own smile, they can see their after as well. And easy to slide back and forth with the way the technology is designed. Brighten the teeth, play with the shade, and show the patient very easily their possible before and after. But not too different a technology than, let's say, Snapchat, where we're putting, ears and noses and other things. Here, it's designed in a much more sophisticated way for smiles. Just a quick mention of one of our sponsors for today, which many of you have met at our monthly lectures, HandsMed. They wanted to share just some of their tools, learning tools they have working right now. For example, iLearn. If you visit their website or go on to their Facebook, LinkedIn, all the courses they are implementing, also webinars right now, are posted there in case anyone has any interest. And these are all products that only HandsMed has on the market right now. And now we're going to be looking at some of the, I guess, more fun part of the seminar, which is some clinical cases. So we'll start with the area of orthodontic therapy. And when we think of orthodontics, I think we all have this mindset of a lot of children and teenagers getting braces. But I think who undergoes orthodontic therapy, the demographic of these patients has changed somewhat over the years. We do have some more mature patients, young adults, or even older adults receiving orthodontic treatment. And when we think of the role of the periodontist in these treatments, it changes as well. Their needs are different. The reason they're getting braces or orthodontic treatment may have changed as well. So the why is quite important. I think that for the younger patients, usually it is congenital anomalies or developmental anomalies that they require treatment for, such as crowding or just lack of balance between the size of the teeth and the size of their jaws. And they need to have these issues corrected or managed. But with adults, they've been using their teeth for a while and they've been caring for them or not so much caring for them for a while. So they may have acquired anomalies where breakdown, caries, restorative work. They may have periodontal disease, which you may remember from some of the previous lectures. It's actually quite prevalent. We have numbers up there mentioning as high as 50 to 70% of adults having some degree of periodontal disease. So this is something that's very important to assess and monitor throughout orthodontic therapy. Some of the different ways a periodontist can help an orthodontist and help our patients throughout getting braces is a frenectomy, canine exposure, aesthetic crown lengthening. So that patient we saw earlier with the gummy smile, what she had is called altered passive eruption, and I'll explain a little bit what that is. We can also help the orthodontist do a complete pre-orthodontic assessment of the support tissues and establish an adequate maintenance protocol for patients with periodontal disease. Soft tissue grafting is often combined with orthodontic treatment, especially if the teeth are going to be displaced buccally or facially, which can thin the tissues. Placement of dental implants and surgically accelerated orthodontics. So here we have an example of a patient that presented about a week before our closure here at the office. She has a frenum that's inserted right between the two upper incisors, and it is so short it actually pulls at her lip. So we can have a look at the contour of her upper lip and see a bump midway that she's quite self-conscious about, and she's very happy to have that frenum removed. And the only way for the orthodontist to close those two upper front teeth and keep them closed is for that to be removed and to have her in a fixed retainer after the space has been closed. For canine exposure, I was mentioning earlier just how valuable CVCTs are, and this is one of the cases where they can be extremely valuable in assessing the position of that impacted tooth. So we can see here the 3D scan or CVCT of a patient whose impacted canine is sitting towards the palatal of the deciduous canine, which is still in place, and palatal to the permanent lateral. So this would receive one kind of surgical therapy where we expose the tooth through the palate, place a button, and allow the orthodontist to bring that tooth down into the arch. It's not always the case, so here's another example where the canine is actually facial. So it is sitting on the cheek or lip side of the patient's mouth, and the only way to diagnose either of these is through a CVCT. Every so often on palpation, we might feel a bump, but not in all cases. And here's a very classic case with a missing lateral. One of the theories is that the lateral actually guides the canine down into eruption, and this patient lacking a permanent lateral, she only has her deciduous there in the panoramic image, deciduous and deciduous canine. That could explain why that one canine, the 2-3, is impacted. So this case, in addition to planning for bringing down that canine, treatment has to be planned for the missing permanent lateral. Another area that we were talking about earlier was the gummy smile, and a little bit of entertainment before we jump into that.
In this business, everything matters. One little slip, and you are yesterday's news.
This is thanks to you, you know what I mean?
And people say to me, like, you're so good at this. You're incredibly talented. It must be easy for you, born with a mouth like that. And I'm like, yes, but it didn't happen overnight. It took me years to perfect this. Had to learn my regimen, had to learn my ratio.
Ratio?
LTG, lips, teeth, gums, especially gums. Too much, too little, you're toast.
So as orthodontists plan treatment, they don't just look at the teeth themselves, they look at the soft tissues as well. This is a lovely patient who was 20 years old when she presented to my care. She had a history of orthodontic therapy. She'd been offered orthognathic surgery when she was undergoing her treatment, and she actually had that performed. She was unhappy with the gingival display. She still had a gummy smile, and she had had 2 gingivectomies between the age of 16 and 28. She was a quite Google savvy young lady. She'd already found out exactly what she had, and I'll explain that in just a second. If we look at her photographs, we can see just a mild discoloration on her 1-1, slightly gray, but we can't see that much of her teeth either. We planned treatment for her based on what she actually has. So when our teeth are coming into our mouth, once the tooth is actually positioned in the final spot where it should lay, the soft tissues and hard tissues still need to migrate. So in figure 1, we can see the different stages of that passive eruption. The tissues are initially on the enamel, and they are supposed to migrate a little bit more towards the root. Stage 4 is actually already recession, when some of that root is exposed. When we have this natural passive eruption that is interrupted or incomplete, what the patient's diagnosed with is altered passive eruption. And it can consist of a couple different conditions. One where the bone did migrate and the soft tissues did not, or as is in the case of this patient, the bone did not migrate, so the soft tissues did not migrate either. So in her case, when we did some probing the patient was numbed and we could feel where the bone was. I could feel the bone is completely sitting over the CEJ. So there was about 1 to 2 millimeters, and once I did her flap, that was even more evident. There were about 2 millimeters of bone sitting over the enamel. So instead of having another gingivectomy done, as I said, I saw her bone in a flap. That's what was performed for her. We planned prior to treatment, though, exactly where we wanted that gum line to sit. So she had a very good idea of what treatment she was going to receive and what the result would be. Treatment was provided. We reshaped both the gum and the underlying bone, and now the gum migrated to the correct position. Now, when we do that, we don't just cut the bone blunt. It has to be recontoured to have some healthy soft tissues sitting over the gum line, and also for that gum position to be maintained. And in doing that, we actually modified the anterior posterior volume of bone around those teeth. If you look at the two upper photos, her smile actually changed as well. It's not going up as much. Her upper lip does not get pushed up by the excess horizontal volume of bone. So we did not actually expect for her lip to change that much, but I think a little bit of practicing in the mirror and the anatomical changes really helped her achieve this result. And she was very, very happy and not afraid of doing the procedure again, because it actually was not as hard a recovery as she would have expected. And now she'd like to have the same procedure done on her lower teeth. And pre-orthodontic periodontal assessment. So I get asked sometimes by a referring dentist, general dentist, or hygienist who needs to see a periodontist prior to braces. And was mentioning some of the differences between younger patients and adults. And that adults have a higher risk of having some acquired anomalies like periodontal disease. So I would say that for younger patients, if the orthodontist or general dentist providing orthodontic therapy have realized that there are thin tissues, there's minimal attached tissue, a frenum that may be a problem, a periodontal assessment is a wonderful idea. But when we think of adults and just how prevalent periodontal disease is and how important it is to have periodontal disease managed prior to jumping into orthodontic therapy, I think most of our adult patients would get a great benefit from having a full periodontal assessment. So this is assessing, as I was mentioning, the same things we assess in the younger patients, but also ensuring that their periodontal health is ideal. And this is an example of a patient who was missing several teeth. She's a 32-year-old female. She actually had a very difficult youth when it comes to dentistry. She had what we would call today we used to call aggressive periodontal disease. She lost several posterior teeth. Her premolars are all waxed up there on the scans in gray. So those teeth are actually not present. She lost those all at the age of 18. She was very good at her periodontal maintenance for a few years when she received treatment and lost those teeth. But for the last few years, she has not been maintained adequately. So she again has some 5 to 6 millimeter probing depths, and she has a lack of posterior support, which has caused her teeth to splay forward. We can see them, just how inclined they are and the spaces between them. And she is currently unhappy with her smile and also unhappy with function. So here we were able to plan this case with the orthodontist. This is a case that's going to involve several specialists since we are replacing teeth after her orthodontic treatment with dental implants. Restorative treatment will be required for that. This was actually a great learning experience for myself, and I think for the orthodontist I was working with as well, because there were several back and forths regarding this treatment. We can see on her upper posterior, one of the areas the orthodontist had planned, and the software had helped him plan, for 2 implants on the upper right in a 12.4 millimeter space. Those of us that work in the world of implant dentistry know that that's not quite enough space for 2 teeth and 2 implants. And it's kind of on the larger side if we're planning to just place 1. Since the patient was undergoing orthodontic therapy, my suggestion was, well, why don't we make the space ideal and have it reduced to about 10, 11 millimeters, or increase it to actually 14 millimeters, which is the minimum space required for 2 adjacent implants. And that prompted a great learning experience for myself, because I started to explain just how, which is quite logical, just how challenging it can be to move that remaining molar. But then after discussing a little bit further, we realized actually moving that molar mesially would improve the way it contacts with the lower molar. So if we could achieve this, it would be a wonderful thing to do for the patient. The matter was just trying to figure out how. So in the end, after discussing a few options between us, we decided that what we would do was do as much of the orthodontic therapy that could be done first. Once that was stabilized, the dental implant was going to be placed in that space. We would do it a little bit earlier than we had initially planned. Once that implant was integrated, it could be an anchor to help move that molar forward, because we'd have something very stable to fix the wiring to. So that was the patient's final treatment plan. And she was very happy to hear that this had been discussed and planned for her. And I think both the orthodontist and myself were very grateful to have had the opportunity to learn a little bit about each other's specialty. Another question that pops up a lot between orthodontic patients, and sometimes it's dental assistants who hear this, or it can be the dental hygienist or the general dentist who will say, I have gum disease. Am I even a candidate to get braces anymore? And the reality is, with the correct steps prior to, any patient, almost any patient, is still a good candidate for orthodontic therapy. And what are these steps? Well, we mentioned already the pre-orthodontic assessment, treatment, reducing the pockets, maintaining them adequately throughout the orthodontic treatment with close monitoring. When we move teeth, inflammation is caused, and that's part of what helps bone resorption and bone apposition, that pressure that orthodontists apply to the teeth. If there's inflammation in the gums, or there are pockets that are not being well maintained, and the orthodontist is moving these teeth, that inflammation will stop the new bone apposition. So we won't get bones, we'll get bigger pockets. To prevent that close monitoring, the maintenance of the periodontal tissues, both the home care and the professional care, are extremely important. So that plan for maintenance should be in place as well prior to orthodontic treatment. So periodontal treatment and maintenance both need to be provided prior to care. But patients who have crowding, who have difficulty flossing and cleaning their teeth, can actually benefit greatly from having their teeth repositioned. Soft tissue surgery is another area that we work closely with orthodontists in. This is a patient actually post-op. So this patient had a little bit of bone loss in between her roots. Recession was somewhat more pronounced than it is on this post-op photograph. But if you look at the left and right, it can be quite challenging in this type of an image to detect where that graft has been placed. Initially, though, the recession on the left side was a little bit more pronounced. And if we look at this image, I don't think we really doubt that much anymore where that soft tissue graft is. We'll do this sometimes pre-orthodontic therapy. If teeth like these are going to be moved facially, it'll be much harder for those teeth to be pushed through the bone and soft tissue if we have some nice thick tissue protecting the roots. Sometimes this is provided after orthodontic therapy when we see recession has begun and the risk of progression is high. Having nice, strong, thick tissues can make the area much easier to maintain and much less prone to having further recession. Placement of dental implants is often required in orthodontic patients as well. Here we have an example of a patient that presented to the clinic a few months ago. She already had her orthodontic therapy performed, as you can see by the retainers on the lower and upper teeth. but she was missing her 2 laterals. The CVCT, again, is a great technology to help us diagnose and treatment plan this patient. You can see how thick the bone, the residual bone is on the lateral position on both the 1, 2, and 2, 2. It's about 2 millimeters thick. So definitely insufficient for a dental implant. Dental implants need really nice, thick bone on the lingual and labial of the implant. We want at least a couple millimeters of thickness, and we want some thick, strong, soft tissue covering that as well. And this patient will be getting her lateral implants placed, but not before creating some of the bone that is lacking in that area. And one of the reasons that bone is lacking is because the teeth never came down and erupted into that position, developing that site and creating bone. Fortunately, though, now with current dental technology, we can recreate some of that, or create, because it's never been there, we can create that lacking bone. This is another patient that presented within the last couple months at the clinic, referred by his orthodontist. He's been in braces for about a year and has a very important event coming up. He was really hoping to get his braces off within the treatment plan, which is about a year and a half, because a family member is getting married, and he's planning to be part of that wedding ceremony. I'm not sure if that's going to happen in current situation. But the orthodontist noticed that he was not going to be hitting the treatment plan in time. This adult patient had very thick bone on the left side of his lower jaw. You can see a slight bump lingual to the canine and premolars. And we can see that in the scan a little bit better in the area of the 3, 3, 3, 4, 3, 5. There's quite thick bone. And as the orthodontist is trying to push these teeth lingually to correct that crossbite, he's finding a lot of resistance. And it's because there's so much thick cortical bone there, and it's an adult patient, so their bone remodeling is quite slow. Surgically accelerated orthodontics was suggested for this patient, and what that consists of is raising a flap. Blue lines there mark the area where we're going to make vertical cuts in the bone. We want to avoid the roots, so I just, those are drawn on there just for educational purposes. But the blue lines is what's going to allow this treatment to progress more quickly. We do this type of procedure with something called a piezo. So it's a very fine instrument. We use it also in sinus surgery, because it is very gentle with the soft tissues, while it lets us do what we need to do on hard tissues such as bone. But tooth is also a hard tissue. That's why in this procedure in particular, we have to be very cautious with those roots. After doing the vertical cuts in the bone grafting is placed over the area, a membrane, and the area is suture closed. And the orthodontist restarts orthodontic movement right away. So for most of our surgeries, we'll be asking patients to delay any other dental treatment for a certain amount of time. In the case of this procedure, we do recommend they see their orthodontist very quickly after to take advantage of that bone remodeling process that's going to be taking place. One thing to keep in mind, though, is an optimal treatment plan should be the least invasive option that will satisfy the patient's expectations and treatment objectives. I would never say that all patients should receive this type of therapy. Conventional orthodontic therapy will satisfy the needs of, I think, everybody without requiring something invasive. But when needed, it is a great treatment option. I don't think that those teeth would have moved not before the summer and not before, a year or two from now. So this was a great option for this patient. So now we're going to move on to the next area, which would be the endodontic therapy. And the linkages are the ways that we as periodontists can support our endodontic colleagues. And that's basically in 3 areas. Root resorption, we saw a case of external root resorption already, which unfortunately we could not work with them to help keep. It was too advanced, but sometimes we can help them. So here I see a radiograph, and hopefully you see it well as well, of some radiolucency within what looks like the canal of that 3-1. These are probably the lesions I've noticed that go unnoticed for the longest amount of time. Reviewing cases with colleagues, sometimes they'll refer a case over with something like this, but when we look at the x-rays from 6 months before or a year before, there were already some very small changes that went unnoticed because we weren't really looking for them. But the earlier this is treated, the better it is for the patient. So it's something for us to be very vigilant of. And only the radiographs are going to help us. If we see this clinically, is because it's advanced so much that the crown has snapped off or the root has become infected because of exposure of that canal system to the environment, to the oral environment. But early on, there's absolutely no clinical sign that this has happened. There's no way to know other than through a radiograph. So it's good to be very vigilant of it. So this is what the PA looked like with that little arrow and that very light radiolucency. When we look at it on a CVCT, which again is the best tool that's going to allow us to determine whether this is something that's actually happening inside the canal system or if it's something that's happening on the lingual side of the tooth or on the facial side of the tooth. In this case, it was happening on the inside, and we can see how thin a layer of dentin is preserved on the facial. So this needs to be treated pretty immediately before that perforation is created, and it will have a good prognosis with that root canal treatment being provided. And actually here, I was able to sit back and ask my endodontic colleague to perform treatment without having to provide anything else on the periodontic end of things. When we have external resorption, it looks a little bit different. It doesn't look very different on a radiograph though, on a conventional 2-dimensional radiograph. But on a 3D radiograph, we can see that perforation on the facial. It tends to be quite aggressive. It can progress rather quickly. And again, there's absolutely no symptoms, no clinical manifestation. It's caught on a 2D radiograph, and then the CVCT is requested. This patient was caught a little bit too late. This tooth is no longer restorable and had to be removed, and then was replaced with a dental implant. So this would be an example of external resorption, a little bit different than the first case we saw in the beginning. So the first case in the beginning, the root was lost from the apex down. And in this case, it's cervical external resorption. So it eats away from very close to the gum line, but not even during a hygiene visit would this be noticed. It's too far underneath the gum line and underneath the attachment of the connective tissues. So if it's found during a hygiene visit, it's because it's already quite advanced. We want to detect these in class 1 or class 2, which is in those stages where it's actually very, very challenging to diagnose, because if it's stage 3 or 4, many times the tooth will not be restorable. In class 1, 1 and 2, if we still have an intact canal system, this is treated only surgically. In a class 3 that we deem is still restorable would be combined endodontic therapy with a flap to remove the tissue and seal on the end of periodontal treatment. And class 4 would be no longer treatable, be removed and replaced.
I can jump into that.
Yeah, please.
It's amazing how many times it's the hygienist that picks up the external resorption. So it's really just through the instrumentation that gets picked up, and then it's like, whoa, where did this come from? And this is also one of these things that happens fairly rapidly too. So once you find it, it's always like, why didn't you see this before? And then the patient feels like, well, I couldn't see it because it was you can't see it really on an X-ray until it's like way too late. So, but I'm always happy when we get it in class 1 or class 2 because it's fixable at that point.
Yeah, and hygienists are great resource and a great set of eyes to capture this, as you mentioned, while they're doing their debridements or root planing, maintenance, whatever stage of periodontal therapy they're providing, they can go underneath the gum line and in some cases detect this, but usually it'll be later on. And I've seen a few patients referred over, oh, patient needs a crown lengthening, and they have a big carious lesion because they can feel that dip, but it's not a carious lesion. It wouldn't present so deep underneath the gum line. It is external root resorption. So, I think they're very interesting cases, and we see more and more of them. They seem to find that they can be associated to internal tooth whitening. They can be associated to orthodontic therapy, trauma, and some of them there's really just no explanation on why they present. Here's another case, a couple cases where we can see a little crease in the root surface. Another area we work closely with our endodontic colleagues is in treatment of endoperiolesions lesions and in root fracture. Both of these present very similarly when it comes to clinical presentation. Localized increased probing depth. Sometimes, patients will come in for a maintenance visit and then they come into the next one and all of a sudden a 2 millimeter pocket became an 8. They tend to be narrow increased probing depths as well. There can be separation present. There can be a pre-existing root canal treatment, or in some cases, pulp pathology of an untreated tooth that has not yet been treated for a root canal. And just so we have an idea of what these consist of, sometimes it's a problem that started within the root canal system and has now drained through the periodontal ligament. Those are the cases that we like to see and detect early on because they can be easily treated with a root canal treatment. Cases where it is a periodontal lesion that has now found its way into the root canal system, whether it is through a lateral canal or the apex of the tooth, are much harder to treat because now we have two problems that are more difficult to manage. And C is when the patient had both periodontal disease and had a basic cavity and now requires a root canal treatment. And again, that's very difficult to treat and manage. So A, I would say, is the ideal case to detect, but any of them are good to detect before a patient gets a root canal treatment, because if the problem went undetected and they happen to be case number B when it was actually a periodontal issue that damaged the pulp, they'll get the root canal treatment and they'll still lose the tooth because of the periodontal issue. So it's good to detect them and to have those discussions with patients so they know, just what the outcome will most likely be before they go through a root canal treatment. And root fractures, I'd say, is one of of all these endodontic issues, one of the most common we see in a periodontal practice. Root fractures can be due to trauma, such as the case on the left. And then they can also be due to a tooth that is weakened by history of a large carious lesion, now has a root canal treatment and a post, which we know weakens the tooth. It's required when it's needed to be able to reconstruct the tooth, but the more root tissue that is removed, the weaker the tooth becomes. So that's an example of a root fracture. They can be quite challenging to diagnose. Our gold standard for diagnosis of it is a CVCT scan. Two-dimensional radiographs, it's even more challenging than on the 3D scan. If we can detect it on the 3D scan, that's wonderful. It does have to be open to a certain number of microns. That fracture has to have been displaced somewhat for us to see it. When the fracture is still together and there's no displacement, no space, it can be more challenging, but then we can also go to our secondary changes. So sometimes we'll see changes in the bone that will give us an idea of, yes, this is very likely a root fracture. So this patient actually presented now during this coronavirus crisis with an abscess on both facial and lingual of the premolar. We can see just how extensive the bone loss is. The entire buccal plate has been lost. It's circumferential, so the bone loss is all the way around that first tooth. The scan here helped us also evaluate the molar that has a periapical lesion. So he'll need to see his root canal specialist as well, but at least we know that that can more likely be treated, and the premolar had to be extracted. I think something very interesting on this 3D scan as well is on the 3D reconstruction. So that's the yellow image on the top. We can see a little dip on the lingual bone in the area of the molar. So whenever you've seen a patient that has a swelling underneath the jawline, this is why they get that swelling. When a periapical lesion makes it through that buccal plate, you can see on the image right under it just how inclined, through the lingual plate. You can see just how inclined that area can be. They can have swelling of that space underneath the jawline. It happens a lot on second molars and on wisdom teeth, particularly. Here's another example of a root fracture. We can see on the upper, that's just a conventional 2D radiograph. And both the dentist and the patient were suspecting the swelling he had was coming from the molar, from the first molar that has a pre-existing root canal treatment. But once we did the scan and looked at the bone loss, we saw that the bone loss was actually on the premolar, and that was a tooth that had the root fracture. So very fortunately, the molar had not been retreated or extracted. The tooth that is presenting the issue and requires extraction is the premolar. Okay, and one of the areas we help our restorative colleagues quite a bit is with crown lengthening procedures. We've discussed already a lot about implant therapy with Dr. Fritz in his previous lectures, so I'm actually not going to talk to you about that today, although it's also a very close link between periodontists and restorative dentists. And just to make this a little bit more interesting, I'm going to explain a little bit what a crown lengthening procedure is. We saw the example already of aesthetic crown lengthening. I'm going to explain a little bit what a functional crown lengthening is, and then you're going to help me plan a case. So we're reaching the very end of the lecture, almost there, and I think that last activity will make this a little bit easier to get through last little bit. So when we have a tooth, we have an area where the soft tissues are attached to the tooth. Some of that is epithelium. That should ideally be attached to the enamel, sometimes to the root surface. And we have connective tissue that's also attached to the tooth. That will be done on the root surface. And we have bone that's supporting the tooth. The position where these tissues are on the tooth can be modified if the dentist requires more supragingival tooth structure to be able to restore that tooth. So if they need more tooth to grab onto as they're doing the restoration, if they're doing an interproximal restoration, class 5, or a crown, sometimes they need that margin to be moved. So we'll move both the soft and hard tissues to a position that allows them to have ferrule, so that's enough tooth to support, and also so that their margin is not so subgingival that it will damage those soft tissues and create a periodontal issue. We want to keep that margin of the restoration away from these attached tissues. So sometimes we do it just to preserve that nice, healthy attachment. So here's the case. This woman presented to my care requiring a replacement of her 2 upper crowns. So she has a crown on the 1-1 and on the 2-1. The 2-1 had multiple fractures on the porcelain itself, but had also broken off, and she had very minimal residual tooth structure left. She was unhappy with her smile, wanted to change the gummy smile. Several different professionals can collaborate in designing a treatment for her. She does have a pre-existing root canal treatment on her 2-1, and she's very lucky to have nice, long, healthy roots. So yes, pretty much all of the above. We can see that her soft tissues have some inflammation, so it does not hurt to have a hygienist involved. And actually, a hygienist should be involved in absolutely every single one of our patient cases. They can, and there's not a patient that won't benefit from good periodontal maintenance. The restorative dentist will definitely be involved in designing the new restorations, both on the 1-1 and 2-1. They'll have to determine where they need their crown margins, how much tooth structure they're going to need to be able to support those crowns. So they'll guide that part of the treatment. If our crown lengthenings are suggested because of the limited amount of tooth structure, and the patient decide that that's the way she wants to modify her gummy smile, a periodontist can do an aesthetic crown lengthening, which is actually what this patient decided to do in the end. If we don't need the crown lengthening because there's sufficient tooth structure and she just wants to correct the gummy smile, sometimes an orthodontist can correct that on their own without the crown lengthening portion of treatment. And because she did have root canal treatments that were now contaminated, especially the one on the 2-1, because the crown had fallen off with post included, she needed to be evaluated and possibly retreated by her endodontist to clean that canal again and be able to build a new post. So this patient did receive an aesthetic crown lengthening, new restorations, a new root canal treatment prior to those restorations on her 2-1, and did not want to have braces for 1.5 years. And throughout treatment, between point 1 all the way to the end, she was seeing a hygienist, and she was going to be providing some continued care and maintenance for this patient. So I hope that explains all the people that were involved in treatment. There's kind of the ideal setup for her. And usually at the end of a lecture, I will kind of sum things up. But I think today there's something much more important to say, and that is a thank you for all the people who are helping care for those who are becoming ill, including those nurses that we usually work with here in the office and are right now engaged in activities that, yes, are so helpful for the community, but also they're putting themselves at risk while doing this. So a big shout out and a big thank you to our team of nurses and all the nurses and healthcare providers.
I totally agree. Louisa, thank you for a fantastic presentation. You can see the care, you can see the communication, the clarity, the calm, and collaboration. So yeah, it's fantastic to have you as a collaborator. And it's great to see the network, and we won't shut this down. If people want to stay for a while, that's great. But do we have questions? Any comments, questions, frustrations, aggressions, hostilities? Any questions out there? One of the questions that I was more of a comment is Louisa is very well trained in CVCT, and that's been a focus of our practice for the last few years. But it wasn't always that way. About 5 or 6 years ago, you would have asked me if I wanted to embrace this technology, and I would have said, I don't need this. I don't need to advance in this. But it was so disruptive that it came on, and it just changed the quality of the work that we could do and increased the safety. And now I wouldn't dream of doing it any other way. And I think it's also a benefit that we read the CVCTs ourselves, so that we have an immediate answer. We don't have to wait for that month of turnaround. So that's something that we offer to patients, which I think is working out really well.